I am Jang-Yong Kim from the Catholic University of Korea. Thank you for inviting me here. Today, I'm going to show you the recorded live case about endovascular treatment of in-stent restenosis in less SFA, supported by intravascular ultrasound. 64-year-old man presented with a recent reclaudication in left leg. He underwent open thrombectomy and stenting of left iliac artery and SFA from acute limb ischemia 8 months ago. He had a history of PCI in 2021. He has diabetic mellitus for 8 years, hypertension, dyslipidemia. He was currently a smoker with 40 pack year at the time. Ankle brachial index were 0.5 in right leg and 0.3 in left leg. CT angiogram show ISR lesions in left iliac artery and left SFA. The patient was sent to hybrid operation room and skin preparation was done in right groin. Crossover retrograde approach from right to left iliofemoral artery was done for revascularization. Angiogram showed the restenosis in left iliac artery and the stenting was done in left external iliac artery with the 8 mm EPIC self-expanding nitinol stent. And then angiogram was done to check the femoral artery runoff and show that a stent was occluded with collateral deep femoral artery runoff. Angled catheter and curved Terumo glide wire was used for engaging CTO stump and was able to be advanced to distal SFA with a Rubicon CTO catheter support. After re-entry failure in distal SFA, distal SFA puncture was done under ultrasound guide. V18 wire was advanced proximally and captured by 10 mm gooseneck snare in left common femoral artery. After checking the angiogram of SFA, V18 wire was switched by O14 wire and then pre-balloon was performed by Coyote PTA balloon 3 mm 20 cm length for easy passage of IVUS catheter. Then IVUS was performed. We used the Eagle Eye O14 peripheral image catheter from the volcano, which can see maximum 20 mm vessels in diameter. We recorded IVUS image by manual pullback method. And then we evaluate occluded SFA with the transverse and longitudinal view carefully. We check wire location to confirm the intraluminal location of wire and diameter of artery along the CTO lesions. Diameter of SFA was around 6 mm. We decided to use a large JETstream atherectomy catheter, which can cut 2.4 mm without blade and 3.4 mm with blade up. JETstream atherectomy system consists of a catheter and control pole with a PV console. It has 2 catheters for SFA and 2 catheters for below-knee angioplasty. JETstream catheter need to be advance slowly 1 millimeter per sec. This type filter is usually required for calcific lesions and ISL lesions. Stent can be fractured by atherectomy blade and should be checked with a large view during atherectomy operation. In this case, filter was not placed due to long access and long lesions. JETstream catheter was passed without blade up in 4 times. And then we pull back the catheter and it can aspirate thrombus in the lesion. And then balloon angioplasty was done along the atherectomy side with a Sterling 5 mm 20 cm balloon and 5 mm 20 cm Ranger drug coating balloon afterward. After completion of a PTA, IVUS showed the recanalized CTO lesions along the PTA site without residual stenotic lesion. Puncture site was closed by per-close device. Ankle brachial index after PTA was increased from 0.3 to 0.75 in left leg.